This is Peter Christensen in collaboration with Dr. GoranMohammed discussing the evaluation and treatment of thoracic disc herniations. It's important to understand the spectrum of symptoms and how they relate to surgical indications, as well as how the particular characteristics of the thoracic disc herniation might influence how you decide the surgical approach, not to mention the potential pitfalls and complication profiles of each of the approaches. Thoracic disc herniations are relatively rare spinal pathologies. The prevalence of asymptomatic thoracic disc herniations may be as high as 37%, though, based upon cross-sectional reviews of advanced imaging studies. Symptomatic thoracic disc herniations, however, remain uncommon, with a yearly incidence of around 1 in a million, representing only around 1% of disc operations. The majority of thoracic disc herniations are asymptomatic. Symptomatic patients tend to present with axial back pain, radicular pain, or myelopathy. Atypical symptoms such as chest and abdominal discomfort are possible, and these are often misdiagnosed as GI or cardiovascular issues, leading to a delayed diagnosis. Some patients present with years of workup for vague abdominal and GI symptoms and ultimately discover a thoracic disc herniation may be the underlying cause. MRI is the diagnostic tool of choice, given the excellent soft tissue resolution, allowing for evaluation of myelomalacia and spinal cord signal changes. For surgical planning, though, CT is critical to evaluate the extent of disc calcification and better characterize the bony anatomy. A CT myelogram does combine many of the advantages of an MRI and a plain CT, and it's ideal for those who can't have an MRI. However, it does lack the ability to visualize the spinal cord signal changes. X-rays provide limited information in comparison to CT. However, they can pick up morphological variations, translational anatomy, and provide the size and orientation of corresponding ribs. If nothing else, they can serve as a baseline study to monitor for the development of kyphosis and other post-op deformities. The exact size, location, extent of calcification, and potential transdural extensions are critical details to gather before choosing the approach and performing the resection. The vast majority of thoracic disc herniations occur below T8. T11-12 and T12-L1 interspaces are the most frequent because of their relative mobility and increased potential for degeneration. Around 80% of disc herniations are midline to perimedian, and they can range from soft, partially calcified, to densely calcified. Adhesions between the disc fragment and the dura are common, especially in the large, heavily calcified disc herniations. Here are two examples of non-calcified herniations. On the left's MRCT is a paracentral T11-12 soft disc herniation. On the right is a more central T7-8 soft disc herniation. Examples of partially calcified disc osteophytes. MRI and CT on the left demonstrate the paracentral T9-10 partially calcified disc herniation, and on the right, a central T8-9 partially calcified disc herniation. Examples of the dreaded heavily calcified discs. Here, MRI and CT on the left show a central paracentral T4-5 densely calcified giant disc herniation. On the right, a more central T8-9 calcified disc. Myelopathy or progressive lower extremity weakness attributable to the thoracic disc herniation is a clear surgical indication. Intractable severe axial or radicular pain can be considered a relative surgical indication. Whether asymptomatic patients with large thoracic disc herniations and cord deformity without myelomalacia should undergo surgery remains unclear. In general, prophylactic surgery is not recommended. Isolated back pain, thoracic radiculopathy, and otherwise unexplained chronic abdominal symptoms can usually be managed conservatively with a combination of NSAIDs, neuropathic pain medications, steroid injections, physical therapy, and activity modifications. With the wide variety of surgical techniques and approaches, posterior, posterior lateral, direct lateral, anterolateral, the surgical plan should be tailored to the particular size, location, and consistency of the disc herniation. In general, soft, paracentral, or lateral discs can be removed through a transpedicular or transfacet approach. For large, calcified, centrally located thoracic disc herniations, it's advantageous to use a posterior lateral, direct lateral, or anterior approach to allow for more direct access. Herniations at the thoracolumbar junction do require special attention to diaphragm anatomy, especially if the anterior or lateral approach is considered. A laminectomy alone will not supply adequate indirect decompression from a ventral disc herniation. Historically, disc removal via laminectomy has been associated with poor results, with reports of increased paresis or paralysis in the range of 24 to 75%. Extending a posterior approach by removing the facet or pedicle provides improved exposure and may be suitable for soft, paracentral, or lateral disc herniations. Removal of the facet can result in instability, therefore instrumentation and infusion may be indicated. Posterior lateral approaches such as the costotransversectomy or lateral extracavitary approaches further increase the field of view beyond that of the transfacet and transpedicular approaches. Patients are still placed in the prone position, and laminectomy allows exposure of the dorsal and lateral aspects of the thecal sac from the rostral to the caudal pedicle. The facet complex, transverse process, and proximal rib head are resected. By working under the lateral edge of the thecal sac, the disc space can be directly visualized with minimal cord manipulation. To help free the disc, one option is a partial vertebrectomy. By drilling a cavity in the vertebral body above and below the disc space towards the ventral midline of the spinal canal, drilling the cortical mantle eggshell thin around the herniated fragment allows you to then push the herniated fragment away from the cord into the vertebrectomy cavity. The posterior lateral approaches provide a wide surgical corridor, but are extensive surgical undertakings entailing wide soft tissue dissection with considerable bone removal and post-op pain. Posterior instrumentation and fusion are often required. Anterior approaches via thoracotomy allow an unobstructed surgical corridor for direct visualization of the disc and ventral spinal cord. These approaches are ideal for large midline calcified discs. Once entering the pleural cavity, the parietal pleura over the vertebral bodies is incised. The rib head is drilled away, as well as portions of the vertebral bodies adjacent to the disc space. The lateral aspect of the annulus is excised to access the disc space. Osteophytes arising from the posterior aspect of the discovertebral junction are fractured back into the disc space. The procedure does require an extensive exposure through the thorax, leading to potential pulmonary complications and post-thoracotomy pain. Tight dural adhesions could be hidden behind the disc, obscured by the largely anterior approach. Thoracoscopic discectomy is an attractive, minimally invasive alternative to open thoracotomy. It provides similar ventral access as a thoracotomy, with limited soft tissue dissection and rib resection, leading to less blood loss, reduced morbidity, and faster recovery. Spine surgeons can experience difficulty with the 2D visualization in manipulating long surgical instruments through ports. Although less than an open thoracotomy, pulmonary complications remain since single lung intubation and postoperative chest tube drainage is usually required. Lateral approaches allow direct access to herniated discs at the dural interface. They could be performed outside of the pleural in a minimally invasive fashion to reduce pulmonary complications. The patient is positioned in an orthogonal lateral decubitus position. A mini-open thoracotomy is performed, removing a small section of rib directly orthogonal to the disc, and the retropleural space is developed. The rib head is identified and removed. Then, the pedicle of the lower vertebrae is exposed and drilled away to expose the ventral and lateral aspects of dura. A partial corpectomy straddling the disc space is created in front of the thoracic disc herniation between the adjacent pedicles. Careful dissection is then used to separate the posterior longitudinal ligament and ventral dura rostrally and caudally beyond the extent of the thoracic disc herniation. The lateral approach provides an excellent view of this interface between the disc herniation, ligament, and dura. Once separated, the PLL is cut away, and then straight and reverse angled curettes are used to push the thoracic disc herniation anteriorly again into the corpectomy trough away from the ventral dura. The disc can then safely be removed. Here's an example of a giant partially calcified T8-9 thoracic disc removed through a mini-open thoracotomy with retropleural lateral approach. Postoperative imaging on the right shows the corpectomy site. To briefly summarize, although the majority of thoracic disc herniations are asymptomatic and can be managed conservatively, patients with myelopathic symptoms and those with intractable pain might benefit from surgery. The choice of surgical approach for thoracic disc herniations depends on the size, location, extent of calcification, surgeon familiarity, and the specific complication profiles. Laminectomy alone does not provide adequate decompression in most cases. In general, large, calcified, and ventral thoracic disc herniations are better managed with anterior or lateral approaches, and posterior lateral approaches are reserved for soft lateral discs.